Q&A. Okay, let's see. Got a couple people in the waiting room.
Okay.
Okay, it's 12 o'clock, and it's time for me to say welcome to everyone. My name's Warren Boykin. I'm the Program and Outreach Coordinator for NAMI Northern Illinois. And today, it's my pleasure to welcome you to our discussion, Ketamine, Dispelling the Myths and Exploring Its Application. Today, our special guest is Don Mitckess. He's the Director of Clinical Strategy for Relief Mental Health. He has over 30 years of experience in behavioral health, serving in many capacities. And as a recent convert to the use of innovative treatment modalities and therapy such as TMS and Spravato, he's learning not to discount new innovations that can effectively help those who are suffering. As always, I'd like to invite people to ask questions during the session using the Q&A tab or the chat function, and we'll be holding those questions till the end of the presentation probably, but I'll do my best to not interrupt very often. Don, do you have anything else that you'd like to add before we get
Well, no,
started?
do feel free to ask questions during, because I'll just keep rolling. Feel free to interrupt and ask a question, because if someone has a question that's on the top of their mind, I'd rather be able to address it as we're talking about that particular part of the topic. It just makes it more meaningful, and this way we don't forget to ask the questions at the end. And so yeah, feel free to chime in and let me know if someone has a question.
All right. Well, and because this is a webinar, it's being recorded. We'll upload this to NAMI's YouTube page probably in the next 24 hours after we finish. Um, so if there's somebody who could benefit from this information that wasn't able to attend, invite them to look at our YouTube page. Just search for NAMI Northern Illinois on YouTube. And of course, we've got our webpage, always informational, www.naminorthernillinois.org. Uh, without further ado, I'll turn it over to you, Don.
Great, great, excellent. Thanks, Warren. I appreciate it, and thanks for the opportunity to come and talk on this topic. So we're here to talk about ketamine. Ketamine is it's a bit of a controversial topic, without a doubt, in the behavioral health space. Full disclosure, I'm an addictions therapist, and I've treated people for ketamine addiction. So I was a bit of a skeptic about ketamine and its use in a therapeutic setting for behavioral health. And um, you know, I did the research. I talked to clients. I talked to the pharmaceutical companies. I talked to doctors. I looked at the peer-reviewed research, and I'm here to tell you I'm a bit of a convert. So we're going to talk about why, and talk about how it can be used, how it should be used, how it's just as important how it shouldn't be used. So we're going to dive in, and here's our okay, here's our agenda. Here's what we're going to talk about. How did we get here? We're going to talk about how ketamine, where it came from, and how it got here today. How does it work? What's it good for? We're going to talk about some ethical considerations, and we'll address your questions and concerns or have a discussion. But as I said, I invite you to ask questions as we go. And Warren's going to be monitoring that, so we can. I like discussions. Webinars are not always easy to have discussions in, but I do appreciate questions and be able to answer any questions you might have. So, how did we get here? How did ketamine get from when it was developed to how we're using it today? So it was actually developed as an alternative to phencyclidine, or PCP. It's a derivative of PCP. And PCP back in the early 60s, late 50s, early 60s was being used as an anesthetic, right? So you hear PCP and you're thinking street drug, which is correct. That's currently where it's available, for lack of a better term. But it was used as they were looking for an alternative to PCP as an anesthetic because people who were coming out of the PCP anesthesia um, were having psychomimetic reactions. They were, lack of a better term, they were freaking out when they're coming out of anesthesia. They were more likely to have behavioral disturbance, emotional disturbance as they were coming out of the PCP anesthetic. So they were looking for something that was a better option. So, the bright scientists came up with ketamine, which is a derivative of PCP. It's your there people are It's a dissociative anesthetic, which means it creates a disconnection between body and brain, right? Dissociative. It makes it's favorable over PCB because you know what, people were less likely to freak out coming out of it, and it had a shorter duration, so it was better. They were better able to titrate it, right? And then it was approved for field surgery purposes during the Vietnam War in 1970. And it's actually on the World Health Organization's list of essential medications because ketamine is on every ambulance. It's in every emergency room because it's really effective at people who need both sedation and pain management. So it's still regularly used in emergency settings. It's still regularly used out in the field. So it still has medicinal uses, but there was a pretty strong period of time where ketamine was being promoted as a club drug, um, where aside from being used in ER or out in the field for EMTs, it was also being used by veterinarians for anesthesia for small animals. And there was quite a long time where vets were being broken into in order to steal this medication so people could use it to get high. So so that's kind of where we came through to it. And in the early 90s, one of the things that they had researchers had found was that it blocks the NMDA receptors, which cause an antidepressant effect. So that was an interesting side effect of one particular study, but it really wasn't dug into until about 10 years later, where some folks at Yale did the first double-blind controlled study of its use as an antidepressant, and they utilized what's considered sub anesthetic. So it's not creating an anesthetic effect because the dosing was much smaller. Um, and upon further study, right, and it was being delivered by IV. So, and upon further study, another study that was released in 2006 showed that IV ketamine had a very high effectiveness rate for treatment-resistant depression, which is what TRD stands for. Treatment-resistant depression is defined as someone who continues to have significant depression symptoms even though they've tried a couple of different, at least two different trials of two different antidepressant medications. So they've tried an SSRI like Prozac or an SNRI, and they're still symptomatic. So those folks where it's been more difficult for oral medications to relieve their symptoms, IV ketamine was helping 7 out of 10 people. So fast forward a dozen years, and the folks at Janssen Pharmaceuticals did clinical trials of a intranasal or a nasal spray version of a ketamine isomer, which was FDA approved in 2019, which is now known as Spravato. That's the brand name of the drug, is Spravato. It's the one form of ketamine that is FDA approved. which is important. And we'll talk a little bit about the science of it and why it's different than IV ketamine. So how does it work? So for me, so what the ketamine or S-ketamine, which is Spravato molecule, does is it binds to the NMDA receptor in the brain. And when it binds to that receptor, it causes a release of glutamate. Now, there's glutamate is an excitatory neurotransmitter. So what that does is it causes the production of all the other good neurotransmitters we have, like serotonin or epinephrine. It causes it's an excitatory response. It gets the brain, it jumpstarts things as far as release of other neurotransmitters, right? So we look at SSRIs like Prozac and antidepressants that affect the serotonin system, but serotonin only accounts for about 20% of mood regulating neurotransmitters. Glutamate is the other 80%, right? So you have two systems in the brain that when they're in balance, right, causes a balance of mood regulation, which is glutamate and GABA. GABA is a slow down. Um, uh, GABA slows down is an inhibitory factor, is an inhibitory response. Glutamate is an excitatory response. So when they're in balance, the brain and mood regulation is in balance. When the glutamate production is lower, GABA is going to be more in control and is going to be promoting to a lowered mood. So what's that mean? So ketamine provides a really rapid and significant relief from depressive symptoms. So it kicks in really quickly. Oral medications typically take weeks before they have an impact on someone's mood regulation, right? You're going to be, if you start on a medication like Prozac, you might feel a little bit of an effect after 2 weeks. You'll feel a more significant effect after 4 weeks, and you get the maximum effect from that particular dosage, typically 6 to 8 weeks after you start the medication. Ketamine can provide significant symptom relief within really 2 doses, 2 to 3 doses typically. So ketamine can provide relief in hours, not weeks. I mean, it can be very, very quickly. People can have a positive response within even the first treatment. Um, so that's very incredibly significant when it comes to folks that are having very serious depressive symptoms, because it can pull them out of that depressive state in pretty rapid fashion. One of the things that ketamine also does, it promotes neuroplasticity and synaptogenesis, which means it promotes the formation of new neural pathways, right? It makes the brain more ready to learn new things in new ways. It's going to help the brain make new connections. It's also going to help with promoting the generation of new synapses, which are the connections between brain cells. And think about other oral medications, your SSRIs, your SNRIs. They're only really effective while the medication's in your system, right? So when you stop taking the medication, you lose the benefit of it, right? It's if you're not titrated down, you can actually have a withdrawal syndrome from it. But the idea is that once you stop taking a Prozac or an Effexor or a Lexapro, you lose the benefit of it. The thing about ketamine is that because it is promoting this neuroplasticity and the synaptogenesis, where it's creating new neural pathways, it's creating the opportunity for the brain to hardwire these new pathways in. The antidepressant actually persists long after the drug is worn off. Think about that. People can do a course of ketamine treatment, and the antidepressant effects will persist long after the drug is out of the system. Um, for instance, Spravato, it's an intranasal. It's in and out of your system in the matter of a couple hours. So the drug is long gone, but its benefit persists after the medication is out of your system. So ketamine is a full ketamine molecule is actually two different mirror opposite compounds, R-ketamine and S-ketamine. So that's a full ketamine molecule. And what the folks at who developed Spravato did was they cleaned up some of the less desirable effects of ketamine by removing the R-ketamine part of the molecule, right? So it has less of the more potent dissociative and anesthetic effects that a full ketamine molecule does. But because it's delivered intranasally, right, it's going up into your nose, and the way it gets absorbed into your bloodstream gets to your brain. This is absorbed through the mucosa or in your sinuses, right? And that it gets absorbed through that mucosa, it gets into your bloodstream, goes to the brain. But because it's being delivered in that fashion, the formula needs to be a little bit more potent, which also, by removing that R-ketamine part of the molecule, makes it a more potent antidepressant effect, right? And it binds harder. It binds 2 to 3 times harder to NMDA receptors, which, again, remember, it's that binding to those NMDA receptors that causes the glutamate release. Okay. This is getting like sciencey and brainsy and stuff. So I hope everyone's following. If anything, if anyone needs clarification on something, please let me know. But the idea here is that um, Spravato, which is S-ketamine, is going to have a greater antidepressant effect with less of the less desirable effects of ketamine. Okay, which is one of the big reasons why the FDA approved Spravato versus giving approval to IV or intramuscular ketamine. Okay, um, because there's less of the anesthetic and dissociative effect that you get with a full ketamine molecule. So on the horizon, as they continue to refine the research on this medication, and what they find is that um, when you take when you do ingest anything into your body, whether it's a drug, your liver breaks it down to what are called metabolites, right? So it actually breaks down anything you take into your body. It breaks down medications, and sometimes those metabolites are the thing that are actually causing the desired effect. So what some recent research is showing is that the metabolism of ketamine to HNK, which is hydroxynorketamine, is what is responsible for the antidepressant effects, and it doesn't have the dissociative and anesthetic effects that full-on ketamine does. So as we refine our research on how this medication, how this drug works, we're really drilling down to what is it that is actually causing the antidepressant effect, right? So it's not the ketamine itself, but it's what the ketamine is broken down into as it's metabolized by your liver. Okay. So we're further refining it where we can, because and we'll talk about what guardrails and what things need to be, monitoring needs to happen when someone is taking ketamine. But as we further refine this and kind of pull away some of these less desirable effects, it'll become safer and safer to use. So, is it safe? It's a big question, right? Is it safe? So the most common side effects are sedation and disassociation, meaning you feel disconnected from your body. And the kind of more important ones are tachycardia, which is an increased heart rate, and hypertension, which is increased blood pressure. So if someone is being treated with some form of ketamine, whether it's IV ketamine, whether it's Spravato or intramuscular ketamine, they need to be monitored in office for at least 2 hours. And during those 2 hours, their blood pressure, their pulse, their oxygenation are all being monitored because of these potential common side effects. But the thing about these side effects, these potential side effects, is they're transitory. I mean, they're gonna resolve within that 2 hour period, with the exception of some sedation, which is why, if someone is uh, receiving ketamine or some form of ketamine treatment, they need to have a ride home. They're not supposed to drive or operate heavy machinery until they've had a night's rest, right? Until that drug has fully worked its way out of your system. But as far as the more, the more potentially concerning side effects, such as the tachycardia, hypertension, those all will resolve within that 2 hour period. So the if you're a provider providing Spravato, because Spravato is FDA approved, it's part of a system called REMS, which is risk evaluation and mitigation strategy. And the reason for that is it should be monitored, because you don't want someone to be able to go to one clinic and receive Spravato treatment and then go to a different clinic and receive Spravato treatment and go to a different clinic to receive Spravato treatment. They need to receive all their treatment at one place, and that's what REMS does. Is they get registered with REMS, so this way they can, that disbursement of Spravato is being monitored, so someone is not just going to get a little high and going to multiple places to be able to do it daily. So it's a system that everyone who is being prescribed or delivered Spravato is monitored to make sure that they're not clinic shopping and going to multiple clinics. Unfortunately, ketamine does not have that same system in place, IV ketamine, because it's not FDA approved. So we'll talk a little bit about that when we talk about ethics and ethical considerations. So because it is FDA approved, there's a lot more research that's available on esketamine or Spravato, and a recent longitudinal study has shown that there are no long-term side effects from continued use, for as much as 6 years. Um, and we'll talk about the treatment regimen, but that's important because there are people that have, we started providing Spravato treatment almost 3 years ago at Relief, and we have people that are still coming and utilizing Spravato as a maintenance medication, much like they would be taking a daily oral antidepressant. So what's it good for? What are things that are clinically appropriate for ketamine to treat? Um, so ketamine, what it was originally studied under was IV ketamine infusion. So it was being delivered by intravenously, right? So IV ketamine is not FDA approved yet, but it has off-label use for major depression, treatment-resistant depression, post-traumatic stress disorder, anxiety disorders, bipolar depression, substance use disorders. These are all conditions that IV ketamine has been shown to be helpful for. Now, what's the treatment regimen look like? So typically it's 6 infusions over the course of 2 to 3 weeks. So either twice a week for 3 weeks or 3 times a week for 2 weeks. The appointments are about an hour and a half. So it's because it's IV, the common side effects, hypertension, tachycardia, things like that, are going to happen quicker and in a shorter, it's in and out of your system a little bit quicker than when it's delivered intranasally like Spravato. So with this course of 6 infusions, what we're seeing is a jump start, right? It's very, very, what we find IV ketamine most helpful for, is for folks that have severe depression with chronic suicidal ideation. Not that they're at a point where they have a plan and are planning on acting on that plan, but for those folks that are living with daily severe hopelessness and helplessness, these chronic thoughts of not wanting to be here. IV ketamine is very helpful at pulling them away out of that hole very quickly, very quickly. Typically within the first or second infusion, they're able to that those more severe thoughts and severe depressive symptoms um, are better controlled. They're improved, much improved. Um, and it acts quicker than Spravato does in that circumstance. It's not unusual for someone to start with an IV ketamine and then switch over to Spravato once we get their more severe depressive symptoms stabilized. Um, that's something that can be done. Um, so Spravato is FDA approved, right, for treatment-resistant depression and major depressive disorder with suicidal thoughts or behavior. So this is also effective in helping those folks that are have chronic hopelessness and helplessness thoughts. It's just not quite as quick as IV ketamine, but the big difference is that Spravato, since it's FDA approved, is covered by insurance. IV ketamine is not. IV ketamine is a fully out of pocket expense, but Spravato is covered and covered very well by insurance. So, but insurance does require most insurances currently, and there's some changes to this, do require that someone be on an oral antidepressant in conjunction with Spravato. They do have to be over 18. It does have teratogenic effects, so they do need to have pregnancy tests before they can start Spravato treatment. And the big thing is that insurance companies look at bipolar disorder as an exclusionary diagnosis. There was a concern in the FDA trials that Spravato or ketamine could trigger a manic episode. Now, there wasn't a lot of good data on that, but that was a concern enough where bipolar is exclusionary and insurance wouldn't cover it. Now, we have successfully treated people with bipolar on the depressive end of their cycle using IV ketamine. And IV ketamine is an out-of-pocket expense. IV ketamine is much more affordable than Spravato is. Spravato self-pay is stupid expensive. I won't even tell you the number because it's ridiculous, but it's covered very well by insurance. So what's the dosing schedule for Spravato? So the first 4 weeks is twice a week. We start out with those little nasal inhalers that look like a Flonase bottle. Each of those provides 28 milligrams of the medication. The first dose is going to be 2 bottles if they tolerate that 56 milligram dosage. As soon as the second appointment, they'll move up to 3 bottles or 84 milligrams. So weeks 1 through 4 is twice a week. That's the induction phase. So we're providing a jump start, right, by causing large releases of glutamate twice a week. And then after week 4, we'll switch to once weekly for weeks 5 through 8. And beyond week 8, we're looking at whether or not weekly or every other week is appropriate. So there's a reevaluation that occurs. Some people stop after 8 weeks and still continue to get a benefit from it. Some people do find that they need to utilize Spravato as a maintenance medication and will continue weekly or biweekly. What we will see is that if it's less than every other week, there have been places that have tried once a month. The research shows that once a month is not as efficacious as every other week. Once you get past every other week, the efficacy goes down. Let's see here. Oh, there's a Q&A. What is that? Okay, so asking about the sublingual microdosing. So it's another form of administration of ketamine. It's just a different way to get it into your system rather than going intravenously or intramuscularly. The sublingual dose is just going under the tongue and is being absorbed by the mucosa in your mouth and cheeks, right? So it's just different, but it's still it's still not FDA approved. It's just a different way of delivering it.
Yes, Don, as you mentioned, there was a question in the chat
Mhm.
It says, what's the rationale behind the need to take an oral antidepressant with Spravato?
So the rationale is that it's they were FDA was not convinced that the study was that it was effective enough without the oral antidepressant. However, the FDA has approved it for monotherapy, which means that you don't need to be on an oral antidepressant, but the insurance companies are slow to adopt that condition, right? So there are a couple of insurance plans, Aetna, Cigna, for instance, that will still cover Spravato without being an oral antidepressant, but there are some that still require that. The FDA has, been convinced by the research that you don't need to be an oral antidepressant to get the benefit out of Spravato. But like everything, even though the FDA says it's cool, the insurance companies have taken their sweet time to adopt it because that indication, that FDA approval came in January of this year, but we're only starting to see it mid-year where insurance companies are starting to adopt that it's okay to be a monotherapy.
Ah, and the second question, a little follow-on says, overall, what are the trends in uptake of Spravato in terms of docs prescribing it?
Well,
He, yeah.
here's the thing is that you have to, and we're going to talk about this in the ethical considerations, is for Spravato, it's all in clinic. You have to be at a clinic and monitor for those 2 hours while it's being delivered. That's a requirement by REMS. You have to be monitored. It has to be delivered and administered in a clinic. Um, and there's important reasons why, and we'll talk about that because there's a lot of ethical considerations when it comes to ketamine and Spravato as a treatment modality. We're going to talk about those. But yeah, it has to, as far as it being prescribed by general psychiatry. Um, my as someone that is works for a series of clinics that offers Spravato. My biggest challenge is educating people on what its potential is and what you need to look out for, just like anything else, right? Because I encourage people to be good consumers, and you're going to hear that more than once as we talk about ethical considerations. Good
Mhm.
consumers as far as who you get this particular medication from.
Right. And again, NAMI doesn't endorse or recommend any particular course of
Mhm.
treatment, but
Yep.
just as you're saying, this is for educational purposes, making sure that people are aware
Mhm.
of treatments as the questioner poses, says she's definitely heard of it, but it seems like a lot of people have not heard about
Well, yeah,
Spravato.
that's my biggest challenge is educating people, right? As what it can, how it can be helpful for them or someone in in their family or friends, um, because there are a lot of misconceptions around it, right? Um, and my goal is being able to let people know what it is, what it can do, how it can be helpful, and how to be a good consumer of it. Because you can. I'm sure there are folks who are listening to this webinar now that if they're working with a psychiatrist or the primary care physician on a medication, it's some docs are just, I'm going to put you on a whole bunch of something and let's see, throw it against the wall and see what works, which never seems to work very well. We need to, and that's one of the things I appreciate about NAMI as an organization is encouraging people to be good consumers and be educated consumers. Um,
Right.
and it's very important in regards to this particular type of medication that people are good and informed consumers.
Yeah, and the fact that everybody is so different,
Yes,
there are a lot of people who don't respond well to the oral medications that are out there, and this
correct.
is a newly approved treatment
It's
that
new, it's different, and it's
that
and
could
that
help.
new and different is scary. But here's one of we talked about the side effects, right? Those are the common side effects that we talked about. Um, if you look at the side effects of oral medications, because they're systemic, right? Um, the side effect profiles of oral medications tend to be far far greater than they are for Spravato.
Mhm.
So,
All right. Well, I didn't mean to interrupt, but thank
no,
you
not at all.
for
It's good.
responding to those.
And I ideally, we're going to talk about the ethical consideration.
Okay.
That was my when I started to see ketamine, 10 12 years ago as ketamine being put forth as a treatment for depression. My response was, but it's ketamine. it's I've treated people for ketamine addiction.
Hmm.
So that was things to consider are, and this is more so for IV ketamine. Spravato is fixed dosing, right? It's going to be either 2 or 3 bottles. When it comes to IV ketamine or sublingual or intramuscular, it's the dosing is based on weight. Um, dosing is so important that that you have a good a practitioner that knows what they're doing around dosing. Okay. Indiscriminate dosing can lead to significantly unpleasant side effects. I had a professional colleague that was going to a clinic in the city, and after he had 3 infusions. On his fourth infusion, the practitioner said, "Wow, you're responding really well to this. Let's up it. Uh, let's double the dose, right? Because you're going to get even better effect out of it." And he had such a an adverse reaction to the dissociative effects of it that he actually ripped the IV out of his arm. So dosing and having direct conversations with the provider about dosing is really important. um, Too much of this stuff is unpleasant. It's the dissociative effects can get very, very significant. Um, so it's some things to consider. Who's conducting the evaluation, right? Is it a practitioner that is certified by REMS, which is, if you're going to a clinic for Spravato, they have to be REMS certified um, providers, whether it's a nurse practitioner, a physician assistant, a psychiatrist, whoever is delivering that evaluation has to be REMS certified. Um, Unfortunately, there's a lot of clinics out there that are run by anesthesiologists, right? Whose specialty is putting people to sleep, who don't necessarily have a background in behavioral health, that are just doing this as a revenue stream, right? Another consideration is active substance use been ruled out, right? If someone is newly sober or not sober, right, they may just be looking to go to a place they can legally get high. What's the environment of care like? What's the treatment area like? Where when you're there for 2 hours, how does that where's that clinic have you for the treatment? I've seen clinics where it's half a dozen chairs with cloth dividers in between them, right? Not ideal. It's not an ideal environment of care. I've seen places where they've had 8 recliners in a semicircle with no dividers. Here's the thing: even with Spravato, you're having some dissociative, a little bit of dissociative effect, right? IV ketamine, it's more pronounced, but you don't necessarily want to be someplace where you're having a shared dissociative experience. If you're receiving Spravato treatment, it's a nasal spray, so only about 70% of the dose actually gets absorbed into your mucosa. The other 30% actually goes back down your throat into your stomach and is neutralized, doesn't do anything, just like any nasal spray, right? And the thing is, Spravato has kind of a metallic taste to it and can also induce a little bit of nausea, right? So you don't necessarily, when you have a people that are close together and someone starts to get nauseous or gag because of that, the let's just say if you've ever been to a college frat party, you know what that's like, right? You get a steamrolling effect, a snowballing effect. Are they being medically monitored appropriately, right? You need to have your blood pressure, pulse, and oxygenation monitored. Whether it's Spravato mandates it, right? REMS mandates that monitoring. But if you're at an IV ketamine clinic where that's not required, are they monitoring you appropriately? And who's doing the monitoring, right? Is it someone that's had medical training? Is it at least a CNA, right? Who knows what to do if things go sideways? Or is it a receptionist that's, putting on the automatic cuff and the blood ox monitor and walking away? And are people being routinely monitored through urine drug screens, right? Again, you don't want someone who's, denies that there are any substance use issues, but turns out there are substance use issues, and now you're getting a dissociative anesthetic drug along with someone that may be abusing opiate medication. Now you have someone that's in severe respiratory depression, and you're calling 911, right? So there needs to be, and REMS requires routine monitoring with urine drug screens. So there are a lot of guardrails when it comes to a drug like Spravato because it's FDA approved. But if someone's also providing IV ketamine, or it's just providing IV or intramuscular other forms of ketamine, right? Are they applying these same guardrails? And if they're not, you may want to look for a different clinic. It's ketamine. I mean, that's the bottom line. It's ketamine. It's a dissociative. It has anesthetic effects. If it's when you have a medication like this, just like opiate medications, you got to be careful with them, right? Because otherwise, you're set people up for either highly negative experiences or set them up to develop a use disorder.
Well, and of course, you mentioned the things like hypertension or tachycardia.
Mm-hmm.
So,
Yeah.
um, there was a, question that's in the chat about sublingual um,
Mm-hmm.
ketamine.
I mean,
It
yeah.
says you mentioned that sublingual is not FDA approved, but it's
Mm-hmm.
being prescribed and sold
Yes.
online by multiple
Yes.
vendors for daily
Exactly.
use.
Yes. And hence this next slide. Ketamine in any form is not a take-home medication. It's not. It should not be. Full stop. If you're utilizing ketamine at home, it's put you in a risky position medically. When you have someone who is doing IV ketamine infusions and is going home and taking sublingual ketamine, you wind up with a situation like Matthew Perry.
Mm.
I mean, not to be crude about it, but it's risky to when you have a medication that can affect your blood pressure, your pulse, your respirations, and you're taking it and you're not being medically monitored, you're putting yourself at risk. It needs to, and ketamine in any of its forms needs to be medically monitored.
Mhm. Excellent. Um, Now here's a question, something called KAP, CAP.
Mm-hmm. Yes, ketamine assisted psychotherapy. I think I was going to touch on, but I'll touch on it now. So there is a therapy model, right? So as a therapist, there are different therapeutic models I can use to therapeutically engage with someone. So I could be doing cognitive behavioral therapy where we're looking at reframing thoughts. I could be doing dialectical behavioral therapy where we're talking about distress tolerance. We could be doing exposure response prevention therapy where for treating obsessive compulsive and anxiety disorders where we're exposing people to things that trigger their anxiety and teaching them ways to cope with it in gradually more intense doses, so to speak. Ketamine assisted psychotherapy is the therapeutic model that utilizes the dissociative effect of ketamine to aid the therapy process. So now ketamine in all of its forms can be very helpful in any therapeutic process. But this particular model, what it does is there's actually three steps to it. There's a before the dosing session where the therapist is setting intentions for the next day, where the therapist is actually in the room while someone is in that hour and a half, 2 hour period where they're under the influence of ketamine. And then the next day, they do what's called an integration session. where after the effects of the drug have worn off, they're integrating what they covered in that in vivo session. So here's the thing about ketamine, which is since it is creating it's promoting synaptogenesis and neuroplasticity. It Someone is more able to integrate therapeutic interventions um, with if they're receiving a therapeutic intervention within 24 hours of their ketamine treatment, right? Their brain is more able to absorb it and integrate those interventions. It makes any therapy process more effective. But in this particular case, ketamine assisted psychotherapy is meant to dig a little deeper, so to speak, because it's leaning into the dissociative and anesthetic properties of ketamine, where, in particular, folks that have trauma, you are better able to access and process traumatic events from your past, because the often physical pain that accompanies bringing up traumatic memories that happens in trauma treatment, right? You're better able to tolerate it, and because it's dissociative, you're better able to look at it from a distance, so to speak. Um, there are some clinics that are doing more and more ketamine assisted psychotherapy. They're doing it a lot in Colorado. I tell you, a lot of CAP providers in Colorado. There are more and more here, but again, be a careful consumer, right? Ask where they got their training, right, and what the extent of their training is in that particular model. Just like you would ask any therapist, what's your theoretical orientation, right? What type of therapy we're going to be doing? How is it targeted to be effective for my particular diagnosis, right? If you take anything out of this presentation, be a careful consumer. Do your research, ask the questions, right?
And
Um,
as you mentioned, it's new.
it's new. It's new. So there's not a lot of research on the efficacy of ketamine assisted psychotherapy.
Mm,
So whereas there's robust research on things like cognitive behavioral therapy, dialectical behavioral therapy, exposure response prevention therapy. Um, there's not as so, but I'm not trying to discourage someone from engaging in it. Just ask questions about what their level of training is, because you can get trained in it in as little as a weekend,
mhm,
or it could be a 2-year process,
I
right?
see.
Depending on who
Now,
you're getting training from.
I did notice that there's also a question in the Q&A. Um, it says, is Spravato equally effective for anxiety as it is for depression?
Um, Short answer, not as effective. Effective, yes. Not as effective. And anxiety is off label for Spravato. So Spravato is FDA approved for treatment resistant depression and depression with suicidal ideation. It's not FDA approved for anxiety.
Thank you. That's a very, I think that answers that question.
Yeah. Okay. So let's see. Uh, okay. Very good. So let's see here. Huh, there, we just talked about this. So ketamine is an effective augment to the therapy process, like we just talked about. There are EMDR, eye movement desensitization, and ART, accelerated resolution therapy, which are both therapeutic models for trauma, can can especially benefit from the addition of ketamine, because as we mentioned, is particularly with these two therapeutic models, part of the treatment is uh, bringing up traumatic memories and utilizing bilateral tapping or reframing of the memory, helps reduce the traumatic response when that memory emerges. um, Ketamine can be very helpful in helping people access more traumatic memories easier. There's nothing easy about it. It's a bad term, but makes those memories more accessible, therefore being better able to be processed in the therapeutic model, the EMDR or ART. Let's see. Okay. Here we go. Ketamine assisted psychotherapy. Um, so again, this, and we already talked about this, so we don't need to talk about it more. All right. So questions, comments. We got a few minutes left. Um, I hope this was helpful. Um,
I think so, tremendously. And
yeah.
thank you for putting your contact information. That's usually the
Yeah.
first question I ask. So if you leave that up there,
Yeah,
um,
yeah. Feel free to email me or even get that's my cell phone. I'm happy to discuss more in detail. I'm also happy, even though I work for an organization, we're not everywhere. I'm also happy we are very well connected in the general community as far as who we are confident is in doing good ethical work with ketamine. So I'm also happy to point you in the right direction of someone that is doing this particular treatment.
mhm.
We're fairly confident that you're not going to, be stuck in a room by a receptionist and someone's doubling your IV ketamine dose. So, but there are a lot
Well, we have
of ethical.
lots of comments thanking you for an informative presentation. I did have one question. You mentioned that the liver breaks down things that we ingest.
Yep,
And I was wondering about gene site testing. Do you?
it doesn't cover ketamine. It doesn't cover ketamine. Yeah, gene site testing is good for, are you more likely to respond to a particular class of medication, right?
Mhm.
That's what it's useful for. But it doesn't take ketamine into consideration.
I see. Just kind of too new to be included in the.
Too new. Exactly
Makes
right. It's
sense.
too
Okay.
new. That's
But
the yeah.
wonderful, wonderful. Um, I I have a couple more comments on the chat. I think those are mostly um, just thanking you. And is Relief mental health in the Rockford area, or where are you
Yes.
located?
Yes, we do have a clinic in Rockford. It's in Alpine.
Hmm.
Um,
But you personally are located in the Rockford area, or
So we have Relief has 12 clinics. I work out of our Oak Brook clinic, which is our main, like our first and kind of corporate location, I guess you would say. Um,
ah,
but
that's
we
right.
have,
You're the director, so
yeah, so I got to
there are
cover everybody.
a lot of clinicians that work under you. I see.
Yeah, yeah,
All right. Well, of course, I really appreciate the way that you've addressed the questions uh, so openly. Um, the other thing that I was going to ask, I guess, um, you talked about the fact that this needs to be monitored so that people are
hmm
not abusing it.
right.
Um, and you talked about the dissociative effect, but is my question was to put it back in the terms of does it make a person high, like they used to say in their the
Yeah, I mean
commercials
there
on.
is, sure. I mean there's and that's for some folks that we do have some folks that we treat as Spravato that might have an anxiety reaction to the experience. So someone who has never experienced a mood altering high chemically like marijuana or something of that nature might have more of an anxiety reaction to the experience because they haven't experienced it before. But there is, but it's the dissociative high, I guess you would say, is kind of is mild. Some people describe it as they feel like the rest of the world is kind of quieted down so they can really focus in on their own thoughts, or they
Mhm,
might feel like their hands are disconnected from their body, right? So there is a dissociative effect, but it is mild. So there's a bit of a high, right? And there's a sedative effect.
mhm.
So So to answer the question, long answer to a short question, the answer is yes, a little bit.
Mhm. But and then I guess it takes me back to the original or the beginning of your talk where you said it was has some pain relief type of
Anesthetic,
effect.
anesthetic effect. Yes, yes.
Hmm.
Spravato's cleaned some of that up. And the thing about IV ketamine and sublingual ketamine, IM ketamine, is that it's being delivered in doses that are sub anesthetic. So it means it's not a high enough dose to cause a full on anesthetic effect.
I see.
Doses are much smaller.
Hmm. Hmm. Well, it's interesting that it's applied in cases of PTSD, and I was just wondering about uses with veterans. Has that been studied much?
Yeah, actually, it's the VA is there are some VA hospitals. Each VA hospital is pretty different. VA clinics can be very different as far as what they're willing to do. But there are more and more VA clinics and hospitals that are utilizing Spravato for veterans and that are being treated for PTSD. It's really it can be a real game changer. It could be a real lifesaver. I'm not being overly dramatic about that. It could be a real lifesaver for someone.
Hmm.
And believe me, I was a skeptic coming into this. Uh,
Hmm.
I had some real serious doubts about providing such a powerfully mood altering drug that I've treated people for, you know, to be effective in a therapeutic setting. But with the dosing, the controls, good evaluation. If someone has a history of a substance use disorder, they need a real good solid 3 months sobriety before you do ketamine of any form with them.
Hmm.
Anything less than that is going to put them at risk for relapse. If they have a history of abusing a dissociative type medication like ketamine or LSD, they shouldn't do it at all. Shouldn't do
Hmm.
it at all. It's
But
super
on the other hand,
risk.
people who have severe depression,
Mhm.
things that have not responded to other types of treatment,
Mhm.
yeah, I take it you've seen positive results.
Very positive results, incredibly positive results. And it's effective. I mean, its effectiveness rate, I mean, the research shows that about 78% of people will have at least a 50% reduction in their symptoms, which is a pretty good response rate. So
Hmm.
there's still 1 out of 5 people that it doesn't do the trick for, and that's it. Nothing's going to work for everybody. But then we have other options, right? There's things like transcranial magnetic stimulation not
Ah,
responding to Spravato. So there are other more innovative treatment modalities that can be brought to bear.
well, and that's a whole nother discussion, isn't
Whole
it?
nother thing. I'm happy to talk about that too if you want to have me back. I'll do a whole thing
You,
on TMS
you
too.
were reading my mind. I didn't know you were capable of that.
Yeah.
We're gonna definitely have to have you back to talk about TMS. Well, I really appreciate your time, Don. Um, as I mentioned, this recording will be uploaded to our YouTube page. Look for NAMI Northern Illinois on YouTube. For the recording, probably be up tomorrow. And then check our website for coming, leading the conversation webinars. Um, Don, thank you so much for your very informative talk.
Thanks, Warren. Appreciate it.
All right, everyone. I hope you all have a great afternoon. And this has been Leading the Conversation from NAMI, Northern Illinois, located in Rockford. Have a great day, everyone.